So, good afternoon. Good morning, sorry. First thing is I'm going to give a little bit of history of this patient. A 70-year-old patient has a progressive curve, has failed non-operative treatment, which included medications, physical therapy, injections. The DEXA scan for bone density is 1.8, has a lot of back pain, and no leg pain. So no stenotic symptoms, no claudication. Cannot walk as much as she likes because of the back pain. It stops her from walking. And then she doesn't like her appearance. She has noticed that over the years, the deformity is getting worse and worse and progressive. She's had it since she was a teenager, but didn't have anything done. She did not even have bracing. And she did have ovarian cancer, and she had a hysterectomy, and the cancer was gone, and then she's been cured from that. So that's really out of the picture. So let's start with the simple X-ray. You can see that she has two large curves. There's a thoracic curve and a lumbar curve. And you can notice that the chest and the pelvis are in two different places. So they don't quite line up, and there's a significant coronal malalignment. And so it's a 66-degree thoracic curve and an 80-degree lumbar curve. You already get this impression that's quite rigid appearing at the apex of the lumbar spine. And the lateral, you can see there's some kyphosis between the two curves. So wherever the thoracic and the lumbar curve meet, you can have some thoracolumbar kyphosis. So you can see the measurements on the right. You can see the lumbar lordosis is 39, but then the lumbosacral lordosis appears to be okay, 42. But the thoracic kyphosis is decreased than normal, and there's thoracolumbar kyphosis. So in analyzing these patients, one of the best tips I can give you is to do a supine X-ray. How many people in the audience do a supine X-ray? So that really takes the gravity away and shows you what is happening. You can also do some push-prone X-rays where you push on the apex of the thoracic and lumbar spine. You can look on the bending X-rays, and what is very obvious is that the lumbar spine is not moving. So the next tip I can give you is, if you really want to know what's happening with the anatomy, is you do the CT scan. And the CT scan really explains, is it an intradiscal fusion, or is this the posterior elements, which are ankylosed, and they will not budge when you do the surgery. So in total, it's a very rigid lumbar spine, and the thoracic spine has some mobility, but it's not as rigid as the lumbar spine, as you can tell. And the CT scan really adds to your understanding of the anatomy. So next is the clinical exam. Always examine your patient. So you can see that on clinical exam, it very much looks like the image on the radiograph. You can see her chest is to the right with coronal malalignment. You see a crease in the thoracic spine, and you see the hump on the thoracic spine on the right, and a left lumbar hump with thoracolumbar kyphosis. So this is the picture. Now, before I go any farther to my panelists, I want to ask the audience. So the title was, the levels of fusion, how you would fix the spine, and I've already showed you the analysis. So in your mind, let me go back. So do you just fix the lumbar spine and leave the thoracic spine alone Anybody want to do that? No? Okay. Do you fix the thoracic spine and the lumbar spine both? Okay. And how would you release or fix the rigidity of the lumbar spine? You do just posterior column osteotomies? Do you do some sort of intradiscal release in addition to the posterior column osteotomies? Some more hands, okay. And then how about doing asymmetric pedicle subtraction osteotomy, especially in the lumbar spine, to get that corrected? So you can do the thoracic spine just with posterior column osteotomy, but you add some sort of 3-column osteotomy in the lumbar spine. Oh, so that's pretty good. So I think that those are the options, but I think the major point of the presentation that I was asked to present is the levels of fusion and how to correct. So Javier, you have a question?
Yes, Munish. I would go up, so my UIV would go up, won't stay in thoracolumbar junction, but because of a coronal plane, we have two curves. So I have to address the thoracic curve. But let's play that instead of 66 degrees, that curve is 40, and you don't have to take it into your fusion because it's not, the coronal component is not. If you see the sagittal one, he's with a hypokyphosis. So in which cases would you stop at the thoracolumbar junction having hypokyphosis, or you will go up to T2 or T3? Yeah.
So it's a great point because I personally picked cases that for long fusion for that reason, but if the thoracic spine coronal deformity is not so severe, and if they have thoracolumbar kyphosis, you have to go beyond it. How far you go beyond it is up to you. But in this case, because of the coronal deformity, you have to go high. But there are cases where you can stop not as high as T4, but maybe at T9, T10. So maybe you want to ask the panelists, do they agree with the audience, or they would do something different? They would prefer the anterior posterior approach or the 3-column osteotomy in the lumbar spine, especially with the rigidity. You want to share with me?
I would definitely fuse long here, and I normally do a stepwise release and get as far as needed. So if before removing the pedicle, this is already getting to the place, I would not do more, but it might need the pedicle subtraction here unilaterally. So it's stepwise.
Okay. Very good.
Yeah. Well, Munish, just a quick comment on the compensation thoracic lordosis. You mentioned lying down for the X-ray to see if this compensation is flexible or rigid. Does this change your planning in terms of length of construct?
Absolutely. So I have another case that I'm going to share with you that really tells you a little bit more about that. So I think let's proceed with this case. I did something different than the panelists. So this is, I like to do the anterior approach in some of these patients so I can actually really release the front and then release the back with posterior column osteotomies to not only correct the thoracolumbar kyphosis, but also the lumbar spine, okay? And now if you look, it's more of a more harmonic correction of the lumbar spine, and we have the chest and the pelvis in the same room for a coronal malalignment. Any comments on that, Ibrahim?
I think I don't have to tell you that, but it is excellent results, and you correct at the same time coronal plane and sagittal plane. Okay. And in this situation is quite relatively easy. It's not too easy, but it's relatively easy because the correction of the coronal plane and the sagittal plane are convergent. So both of them work in the same direction. If you had the coronal malalignment on the other side, it would be much more complex to deal with. So you correct the lumbar major curve, and at the same time, the coronal plane, it corrected. And you, actually, also, there's something nice here that L4-S1 lordosis is already good. So you don't have to deal with the lumbosacral lordosis. You just have to flatten the kyphosis at the upper lumbar spine, which was correlated to the major curve. So it's a very nice case. I think what we can learn from this, that if we don't have fusion between the vertebral body, we do not need necessarily to do 3 columns osteotomy. I think this is really the main message from this case. So we can avoid, in some cases, 3 column osteotomies, which is very risky. So this is one of the cases, despite the complete posterior fusion.
Right. That's a great point. I think my preference is always to segmentally correct rather than go to a, so that you can go in a stepwise fashion, releases, front, back, and then if that doesn't work and you need to do a PSO, you can do a PSO, but then finally get the correction. So the release is just what correlates to better correction. So I think I'll finish there and then
Thank
go
you
on to
very
the
much.
next person.
Yeah.